All right, good morning, almost good afternoon, South Coast. It's Mike Sylvia with New Bedford Guide, Fall Reporter, and all the other guides in the South Coast. We're here to talk something very, very important in the community, something that we don't talk a lot about, which is, opportunity to get some mental health if you need it. We've had 2 years of COVID. You just got to go on social media, see how people are on edge a little bit and things that are going on. So we're talking to some of the folks from Child and Family Emergency Service Program. They're located at 543 North Street in New Bedford, right behind Bob's Sunoco. I got the number on the screen there, 508-996-3154. Website is child-familyservices.org. All in the description. If you need that, you click on that. Do me a favor, share this video. Let's get the information out. These are the experts you want to talk to. They're going to give you an idea of what the emergency services are like. I have Pam, she's the emergency services director, and Matthew, he's the mobile crisis manager. So welcome.
Thank you for having us.
Yeah, let me start with you, Pam. So what exactly is the emergency service program?
Yeah, so we call it ESP, right, for short. And what ESP is we are the state program that actually sees individuals who are suffering from mental health issues and also substance abuse. So our responsibility is to assess and determine if a person is safe to be in the community, and at which point then we make referrals if somebody's out in the community. And we can get into that a little bit further, into more details of that later on. But ultimately, we assess for level care. We complete an evaluation, and based on that evaluation determines what is in the best interest of that individual. We see individuals from all age groups. So as little as 2 or 3 to as old as whatever old is, right? So we see people of all age groups. We are predominantly a mass health driven program. However, we're very lucky at Child and Family. We're contracted with a lot of private insurances. So we don't necessarily not take, there's only like 1 or 2 insurances that we don't take. But other than that, we see pretty much everybody, including individuals who don't have insurance.
Yeah, so someone decides they don't want to call and they want to visit. What would they expect when they come for a visit? They knock on the door, ring the bell. What goes on from there?
So our program, we don't close, right? So we're 24/7 all year long, holidays and all. We always are opened. We always have a clinician on site. So the way that it looks is during the day, obviously it's staffed very differently. We have tons of people on site here during the day. And on the overnights, it's a little bit, less staffing, but there's always somebody here. So when they get here, we will ask them, what they're here for. If they're saying, I need to talk to someone, I need an evaluation. We at that point will have them fill out just a basic information. And then once we determine that they're safe to come into the back, we bring them out back into an interview room, and they are then met with a master's level clinician who will sit with them and talk with them and really get to understand where this individual is at and what their needs are and how can we best help them.
Yeah, and a big part of our programming as well is the mobile crisis portion of our programming. So as much as we want you to come here, we can also come to you. We can do that via a face-to-face interaction. We can pretty much meet with someone wherever they are, as long as there's some sort of protection for their privacy, right? We're going to be talking about things that can be very intimate, and individuals need to be able to ensure that their information is safe. So we can come to you physically, or we can also provide a telehealth assessment, whichever is easier for the individual.
Yeah, so it sounds like phone call, telehealth, personal visit, or you can have you guys come out on a mobile visit.
Mm-hmm. Correct. So, and the mobile looks very right. So we do mobile in so many different ways, right? You can go to someone's home, you can go to Dunkin' Donuts, you can meet them out in the corner, right? They can come to the office. We go to schools all the time. We go to doctors' offices, pediatricians. To be honest, it's where is the patient, and that's where we meet them, right? Wherever they're at is where we meet them, and we don't say no to a specific location. As long as it's within our catchment area, we're able to see them anywhere. And one of the nice things about the mobile piece too is, and we discussed this during the last time we met, was our police co-response program, which is also part of our mobile, right? So we also have a clinician out there with a police officer that's able to meet the patient, if there's any risk factors, just to make sure that everyone is safe. But it's really one of the things that we feel that we are really good at is that mobile crisis and making sure that people feel safe being out in the community and that their needs are met.
Yeah, it's great. It's really, people might not want to, leave their house and go somewhere. They might feel it's too formal. So it kind of takes out some of that formalities a bit. Sounds great. So
Mhm.
I guess I'll go to Matt. If someone's in the community and they do want to call, what are some of the reasons they might want to call?
Yeah, so one of the things that I would say is like if you're less than anything, then okay, right? Like I use the terminology baseline, right? So baseline is someone who sort of wakes up every day and this is how they function. If you start to notice that you're not functioning quite so well, you're experiencing some anxiety, there's an increase in depression, a loss of interest in what you're typically interested in, those are red flags. Those are signals that something's not right. And it might be time to meet with somebody, right? Because there's a lot that we can do for an individual sort of at the onset of their symptoms so that they don't reach the point that they require a higher level of care, which is something we can talk about is when someone does require a higher level of care and what that might look like. We really want to provide intervention at the onset so that we can avoid any sort of disruption or out of home placement for the individual, whether it's a child or an adult.
So I
Yeah,
think
these
one
are
of
the
the things
conversations.
too,
No,
I'm
go ahead.
sorry. I mean, I was going to chime in with Matt. One of the things I think is important for people to understand is that when the clinician does meet with a patient or a family member, right, and completes an assessment, at the end of that assessment, they have a conversation with an administrator on call 24/7. There's always somebody on. So a clinician, even though has an idea of what they want to do for a plan, that they've had the conversation with the patient and the family, every single case gets discussed with an administrator on call. So there's that additional support that is 24/7 all year long that doesn't go away. It's every single case gets discussed with an admin on call.
Yeah, what would be, I could see a few reasons maybe why some people, we stigmatize mental health as weakness, right? Sometimes. And that's
Yes.
why the conversations like this are very important, because I don't know there's a human that hasn't struggled with mental health, right? It's just whether some people show it and others don't. And this is a good way we've had a really tough couple of years with COVID, forced to wear masks, isolation. There's a lot of things that can kind of put you over. And, this is the kind of services people need to know about. 24/7 access right there in New Bedford. If you're driving down, Route 6 and you're heading off to 195, it's like right there before you hit, 140. It's right there before you hit the 140 exit. It's not far away. And as you can hear, you have Matt, who's a mobile crisis person. That you don't have to go there. They can actually meet you somewhere or come to you. It's a great thing. So Pam, you talked about insurance, right? What insurance is covered and what isn't covered?
So when it comes to mobile, we try not to say no to anyone, right? So when the last thing we want is for somebody to try and figure out, especially if they're in crisis in the community, like, oh, we don't take your insurance. Sorry, we can't help you. There are going to be times where if we feel someone is really unsafe and we can't stabilize them in the community, that we would send them to the hospital. But majority of the time, we are going to see somebody regardless of their insurance. So like I said, we are Mass Health driven. They are, Matt is a pro at the insurance piece. I always look at him. But overall, if somebody has a Mass Health product or somebody is actually uninsured, it doesn't matter. We see uninsured people and you don't get a bill for it. So that's one of the things I think that people have fear of, especially individuals that are undocumented who don't have insurance and really need an intervention. It's okay to call us. We will see you. We will not bill you. So that's one of the things we do. Pretty much every single Blue Cross and Harvard. I mean, there's so many different insurances, but ultimately it's like 2 of them that we really don't do out in the community, but most of them we do.
Yeah, if you got a question you want to ask, these are the experts to ask. Courtney asks, are you guys doing counseling and psychiatric help?
Mm-hmm. You want to answer that, Matt?
Sure. So part of the emergency services program is providing a brief solution-focused counseling, right? So providing that intervention in the moment. We're not going to be available to sort of provide that ongoing counseling. However, we will refer you to an individual who can provide that treatment for you. So we try to maintain relationships with our providers within our own community so that when they see a referral come in from the emergency services program, that sort of takes precedence over maybe a routine referral. Now, not always, right? I mean, the reality is that we have barriers with regards to access, but we really try to work through those to get the individual the help they need in that moment. So, for adults, we generally will do 3 to 5 days of follow-up with that individual. And so generally that's enough to sort of link them to the next step. And for children, we're able to provide up to 7 days post-assessment intervention. So that can sort of look different depending on what the presenting issues are for the child or adolescent. But we can provide 7 days of follow-up post our intervention, the initial intervention.
The one thing I did notice is that when we have a couple of folks that really take on the referral process, that once we see a patient, if we think they need psychiatry or counseling, that we have we've been really lucky to link them to the provider relatively quick. So when Matt says that we tend to be prioritized, that's actually true. We do tend to be prioritized. So if a patient gets referred, they're more likely to get into psychiatry and counseling sooner by seeing us first versus trying to get on their own or their primary care doctor being the one making the referral.
Yeah. So you don't have to be in a crisis or suicidal call, right? It's actually better to call before you get to that point.
Correct. 100%.
Yeah. And now why is it key to go to you before they might want to call, say, emergency services, as in like 911 or emergency room visit or something like that?
So we always say, right, we want to be an intervention and not a crisis, right? We want you to call us, like Matt said, when you start to feel like you're not doing okay, that's when we want you to call us, right? Because by the time you get into a full-blown crisis, it's much more difficult, right, not that you can't do it, but there's a lot more obstacles in trying to figure out what is best for that patient at that time. If somebody is clear-cut, suicidal, has a plan with intent and plans to follow through, we will assess in the community, but they are most likely going to end up going to the hospital, right? If somebody is suicidal, but they don't have a plan, they're just having these thoughts, right? They're racing thoughts, but they don't necessarily want to follow through with it. You're likely not going to go to the hospital. We're likely going to be able to connect you to services to keep you safe in the community. So you don't have to be in crisis, but even when you are in crisis, it's going to be us that's most likely going to assess you anyways. So one of the benefits of us seeing you in the community is that if we see you in the community and we end up sending you to the hospital, you are way ahead in the game than someone else. So, which means that by the time you get to the hospital, your evaluation is already done. The clinician's already typing it, and we're already looking to get you what you need to get out of that emergency room. If you don't come to us, right, and you go straight to the emergency room, you still have to go through the whole triage piece, get medically cleared, all of these pieces that need to happen. So you're there for 3 to 6 hours, sometimes longer, before we get called. And then we get called and have to go to the emergency room to see you there. So now you've delayed us by 8 to 10 hours when we could have just done the assessment right from the beginning, got you to the hospital, got you expedited from a medical perspective, and get you into the treatment that you need to get to.
Yeah, Matt, if you can give me some common examples of how you would maybe, someone calling a mobile crisis manager like you, what are some examples that you've seen recently, obviously with privacy for some of the pieces, just generalities. What are some of the examples?
Yeah, so, we're coming off of, well, we're not really coming off of, but we're 2 years into a pandemic. So we are seeing a lot of anxiety. We're seeing a lot of depression. Especially for children and adolescents, right? We started the conversation around 2 years of wearing masks, right? And how disruptive masks are to children and their social emotional development, right? So, if you're thinking of a kindergartner who started, school and now they're in first grade and they've never really interacted with other kids, it's going to be really anxiety provoking for them. So we get a lot of calls to schools for kids who are experiencing anxiety, around peer relationships, around transitions from classes because they started, 2 years of distance learning. So generally those are some of the common themes that we're seeing in terms of mental health. A lot of depression, a lot of anxiety. Mm-hmm. For adults, presentations can be more severe. Especially if there's some psychosis or things like that going on for the individual. But for children, a lot of depression, a lot of anxiety.
Yeah. And Pam, what does a follow-up look like? So someone calls, they talk to, someone there, they get some good information and resources. Do you guys follow up after?
Yeah, so everybody's different, right? So we meet the patient where they're at. So some patients will offer them a few days of phone checks, meaning that a clinician calls them on a daily basis, checks in on them, sees how they're doing, or we'll offer face-to-faces, meaning that we're going to see you for 2 or 3 or 4 days, right? Just to check in. Sometimes it'll start with the face-to-faces and then we transition it into a phone check. And then we always let folks know that once we're done, that, you know, if the phone check's done, if the face-to-face is done, that doesn't mean they stop calling us, right? If they have a question, if they have a concern, or if they find themselves starting to go back into the pattern that led them to seeing us to begin with, call us, because the clinicians answer the phone all day long and all night long, and we could talk to them on the phone. Sometimes it's just simply a conversation on the phone that just gets them to what they need. I do want to piggyback on the insurance piece, though, because I think one of the things I wanted to say is that if it's an insurance that we don't take, and you just come in and see us, and ultimately all we're doing is connecting you to a provider, we just write up a note. We write up a note and we can still make the referral regardless of the insurance, right? We can still do the follow-up if we need to with that individual. So it just looks a little bit different from our end of how we write it up. But we still provide the same type of service to that individual regardless. So the follow-up would even look the same, right? If somebody needs a couple of days of phone checks, we're going to do that. For the kid cases, it's a little bit different. We can do up to 7. I mean, we do 7 day. I always call it like the customer service thing, the right thing to do. So we don't get reimbursed for doing this work for adults. We do for the kids, but we still offer the service because it's the right thing to do for the patient. So even though an adult, we're not going to get paid for us talking to them on a daily basis or seeing them on a daily basis, we're not going to stop offering that because it's not fair to that individual because their insurance doesn't reimburse us that we're not going to offer that service. So we offer it no matter what because it's the right thing to do. It is the right thing to say to someone, you know what, you need a couple of days of phone checks with a clinician, we're going to give it to you no matter what. So that's one of the things that we do. And when I tell you, if you look on our board, there's days that we have like 15 to 20 adults on our board that we're checking in on a daily basis on, whether it's face-to-face or phone checks, and the same thing with the kids.
Mm-hmm.
Yeah, the important is don't let stigma of mental health, don't let insurance, don't let any barriers to make that phone call or just stop by 24/7 again. So it's important when it's 24/7 because crisis doesn't know a time frame, right? It's like could happen at 2 a.m, could happen at early in the morning. And I can't stress it enough, the stress I've seen in society for the last couple of years, people on edge, right? You see the videos online of someone yelling at someone for wearing a mask or don't wear a mask, or there's people, mental health is something we don't exercise like muscles, like we exercise the physical body. There's things, and this is a chance to exercise, have a conversation with someone who's a trained professional. Outside of your family and friends, you might not maybe feel comfortable talking to. These are people that'll help you out. Don't let a barrier, don't let a barrier be there from insurance to stigma to stop you from making that phone call. I think if I said that well enough, or
You did.
Yeah.
Yeah. So anything I miss you want to close with? Either one of you?
No, I just say, you know what, if somebody is watching this and they have a question, just pick up the phone and call us, and we can absolutely answer your question for you. If you have a family member that's suffering and you don't know what to do, just call. We'll help you. We'll figure it out. We'll give you some guidance. So I just say no question is a dumb question. Just don't hesitate. Pick up the phone, call.
Yeah. We're your urgent care center for your behavioral health needs. We never want you to go to the emergency department. Please reach out to us first, and we're going to try to connect you with the support you need.
Yeah, it's Child and Family Emergency Service Program, ESP. It's 24 hours, 7. It's right here located in New Bedford, 543 North Street. Bob's Sunoco. If you see that, you can go right behind it. It's 508-996-3154. Or you can type in, Child and Family Emergency Services, but it's child-familyservices.org. Go to the website, get information. Give them a call if you're feeling down or blue. All right. Well, thanks for tuning in, everyone. And thanks for joining me.
Thank you.
Thank you.